Hello, welcome to another session of our digital slide review and sign out. I'm Dr. Louis Hassel and our program part of the Digital Anatomic Pathology Academy, a joint venture of Digital Pathology Association and Path Presenter. I'm coming to you from the campus of the University of Oklahoma Health Sciences Center. And our case is that of a 45-year-old woman who has noted an expanding mass and is found on exam to have a lower pole mass in her thyroid. So this, as in most cases, leads to a needle aspiration biopsy. And here's a representative view of what would be found on that biopsy. We see there's not much in the way of recognizable thyroid type of tissue here. We have a little bit of a fluidish background, some single cells, some chunks of tissue. And then on higher magnification here, we can see that these cells appear to have some cohesiveness and maybe a little squamoid element to them. In addition, there may be a few scattered smaller cells, maybe inflammatory cells in the background, some of these smaller nuclei here. So the lesion is then brought to resection, and we see that the lower pole of the thyroid has a sharply demarcated tumor, very blue, with no evident follicular structures, no glandular or other papillary type of lesions. And it's extending out into the surrounding soft tissue, nearly involving skeletal muscle here. As we come into a little higher magnification, we can see there's a bit of a nested pattern, a few areas of more epithelioid type of appearance with some intervening fibrous tissue, some banding here, and maybe some inflammatory cells. Here we see a nice little cluster of small bluer cells, a little different than these more amphiphilic, diffusely hyperchromatic cells. So we'll come in at a little higher magnification and focus down on this area, and we see that indeed these are lymphoid-like cells. And these appear to be epithelioid cells. Sort of a diffuse background, appearing to be high grade, but there isn't a lot of nuclear debris or necrosis, just a lot of these scattered lymphocytes and a few other inflammatory cells here. So this doesn't look like any of the usual carcinomas of the thyroid. And this lymphoid stroma and very poorly differentiated epithelioid appearing tissue raises the possibility of lymphoma, maybe of lymphoepithelial carcinoma or other related lesions. Maybe metastasis is a consideration. Melanoma, I suppose, could have a configuration somewhat like this, although usually more sharply defined. So this is actually an unusual thyroid cancer, lymphoepithelial-like carcinoma or intrathyroidal thymic carcinoma has also been termed carcinoma showing thymus-like elements, or the nice catchy acronym CASTLE. It does tend to have this nodular expansive growth with a few areas of fibrous bands and moderate numbers of admixed lymphoid cells, the nests and cords of epithelial cells, but usually these have a fairly low mitotic count. Now, we couldn't see very many mitoses in those slide. We might want to do a Ki67 or other marker. Immunohistochemistry can be quite helpful. These will be positive for most high molecular weight cytokeratins, squamous marker P63 or P40, and the lymphoid cells, and sometimes the epithelial cells will be positive with CD3 or CD5. Additionally, these cells express CD117, though they do not have the c-KIT mutation. And BCL2 and PAX8 can also be seen in the epithelial cell component. Importantly, they are negative for TTF1 or thyroglobulin. They also are negative for EBV, which is an important consideration in excluding lymphoepithelial carcinomas arising elsewhere in the head and neck. So with that consideration, What do we know? Well, the differential diagnosis could include medullary carcinoma. It doesn't look a whole lot like that, but with maybe a better differentiated appearance. So sometimes you may want to do calcitonin or other lymphoid markers to exclude that possibility. The lymphoid markers will obviously confirm the presence of the lymphoid component, which would not be expected in medullary carcinoma. Poorly differentiated squamous cell carcinomas, those would also be P63 and high molecular weight cytokeratin positive. But the mitotic index would usually be much higher in conventional squamous cell carcinoma or anaplastic carcinoma with a squamous component. Additionally, P53 can be strongly positive in anaplastic carcinoma and often TTF1. So those help you a little bit with the differential diagnosis of a rare tumor. Um, so our final sign-out diagnosis in this case is a carcinoma showing Thymus Like Elements, or CASL, and it's a rare tumor of the thyroid. We hope that you've enjoyed our program and that you'll subscribe so that you can not miss future releases. And please share your comments. And if you have other particular thoughts, please don't hesitate to reach out to me directly. We love to hear from our viewers, and your suggestions obviously help us in guiding and selecting future cases or topics to consider. So until next time, thanks so much for joining us.